When discussing the topic of the relationship between evidence-based practice and practice-based evidence, uh, one needs to keep in mind that evidence-based practice allows for accountability. So that means basically that the study can be replicated, and when the study can be replicated, it ends up being more consistent. The studies do, and the data gathered from those studies are more consistent. So, when introducing the practice based evidence, which is the PBE, it allows for a more cultural context, so it's more culturally focused. But both evidence based practice and practice based evidence overlap to some extent. The book actually says that the evidence based practice goal is to achieve safe, cost effective quality outcomes by using research based evidence to direct patient care decisions. However, to be fully effective, EBP or evidence based practice requires that the feedback loop provided by practice to determine if the goals of EBP have been achieved in the real world of healthcare delivery. So that's when practice based evidence comes in, and that it overlaps with the evidence based practice because practice based evidence, again, focuses on that more cultural aspect of healthcare. Some PBE or practice based evidence questions that you might ask in a typical, if you want to find data or you're just asking about data. Some of the questions can include: are treatments used in daily practice associated with intended outcomes? Can we predict adverse events in time to prevent or ameliorate them? What treatments work best for which patients, and what type of individuals are at risk for certain conditions? So PBE is in a more in-world context instead of like just focusing on the practice. PBE wants to know like the real world context of that healthcare system. So what exactly is practice-based evidence, or PBE? So according to our book, it is an innovative perspective research design that uses data gathered from current practices to identify what care processes work in the real world. So the difference between evidence-based practice and practice-based evidence, I know it gets confusing, but the difference is that evidence-based practice is about using evidence to guide practices, and then practice-based evidence is used about obtaining the evidence to use from practice. So practice-based evidence is used to eliminate the weaknesses from traditional observational studies. And some of those weaknesses are outlined here, and it is attention to patient characteristics to address how effective the treatment was. So these are how practice-based evidence eliminates those weaknesses. Number two is that practice-based evidence uses many samples and sources to improve how the sample is represented. Practice-based evidence uses strict documentation of interventions, and then practice-based evidence includes frontline clinicians and patients. So with strict documentation about practice-based evidence, that's used for how exactly the patients are cared for, what needs to be changed, and what is working. So each individual needs to be assessed instead of the whole overall concept. There are 6 steps in a practice-based evidence study. Step 1 is to create a multi-site, multidisciplinary PCT. So the PCT identifies outcomes of interest, identifies individual components of the care process, creates a common intervention vocabulary and dictionary, identifies key patient characteristics and risk factors. It also proposes hypotheses for testing and participates in data collection, analyses, and dissemination of findings. The PCT builds on theoretical understanding, research evidence to date, existing guidelines, and clinical expertise and experience about factors that may influence outcomes. So that comes back to earlier where I had said that the practice-based evidence, unlike the evidence-based practice, the PBE uses current information about the current practices, basically. Step 2 is control for differences in patient severity, including comorbidities, treatment processes, and outcomes, which is a comprehensive severity measure, should be an age and disease-specific measure of psychologic and psychosocial complexity. It is used to control for selection bias and confounding by indication. An example is the CSI, that is disease and age specific and composed of more than 2,200 clinical indicators. So this is directly from the book. It's on page 52, where the steps are. Step 3 is implement intensive data collection and check reliability. Capture data on patient characteristics, care processes, and outcomes drawn from medical records and study-specific data collection instruments. Data collectors are tested for inter-rater reliability. And step 4 is create a study database. Study databases consist of merged, clean data and is suitable for statistical analysis. Step 5, test hypotheses successfully. Hypotheses are based on questions that motivated the study originally, previous studies, existing guidelines, and above all, hypotheses proposed by the PCT. Let's see. Step 6 is validate and implement study findings. Implement findings in practice to test predictive validity. In this step, findings from the first 5 steps are implemented and evaluated to determine whether the new or modified interventions replicate results identified in earlier phases and outcomes improve as predicted. After the validation of specific PBE findings, which is practice-based evidence, the findings are ready to be incorporated into routine care and clinical guidelines. So basically, it's the study, the steps of the study is from 1 to 6, and you have to remember that it's creating first, and then at the end you have to verify your study findings. Limitations and strengths of practice-based evidence. So practice-based evidence only works if there's a current clinical practice that needs to be studied, and emphasis on the current, like it needs to be available, real, current. So there's no limitations for settings or conditions, so it literally could be anything. It works in multiple settings. It works in acute and ambulatory care, inpatient and outpatient rehabilitation, hospice, long-term care, and like adult and pediatric care as well. A limitation for this is that it's time consuming. The data extraction and doing the initial steps of the practice-based evidence takes a really long time to gather enough data to formulate a hypothesis and to work it into the actual study. So relevant variables might change in the PBE study, but it has been found to work in various practices. Like I said, it can work in a lot of multiple settings, but it does take that initial oomph to get going. Informatics and practice-based evidence. So when talking about electronic health records or EHRs, it's not always plausible for practice-based evidence to have a study of the electronic health records because it's challenging because the data intensive practice-based evidence that it needs data. That's why it's very data driven, and current practice is what drives it. Electronic health records can have the data aspect, but they are always not research friendly, because the many desired data elements are in text, such as clinical notes, and they can't be it can't be compared to like a graph or anything like a clinician's note of patient did well today on such and such medication can't be worded in such a way that it'd be in the data aspect. Like it'd take a lot more trouble than it'd be worth to gather all the notes from everywhere and transfer it into like percentages. So since it can't be exported directly, it has to be, such as the notes, it has to be manually reviewed, and that's what takes a really long time, the data gathering parts. So it's really labor intensive. So with practice-based evidence, there's a multidisciplinary team approach. That means that a lot of people have to be involved in it, so which ensures differences in patient characteristics and treatments are accurately measured. So the more people you have, the better, the more likely it's going to be correct, that the data is going to be correct, because it's not data friendly, and since there's so many sources and so many practices to collect from, that's why you need such a large team. So the practice-based evidence would need to conduct a rigorous, large-scale observation and probably cohort studies, and so they can effectively like compare and see the differences in the data that they require. And again, the manual part of that would take a really long time, possibly months or even years.